Now that you're familiar with the case, let's take a closer look at it. So the Breslow thickness is a measurement of the depth of invasion of the melanoma, and it's measured from the top of the granular layer to the deepest invasive cell. In this case, the Breslow thickness was measured at 1.2 millimeters. Breslow thickness is the single most important prognostic factor in melanoma and is a very reliable and reproducible measurement. It is the primary factor that determines staging and further management. So both the mitotic rate and the presence of ulceration are both independent prognostic indicators in primary cutaneous melanoma. The mitotic rate is a standardized measurement of the number of mitotic figures per millimeter squared, and higher rates are associated with more aggressive tumors. Ulceration represents the complete loss of the epidermis overlying the tumor and also indicates more rapid growth. Ulceration is part of the T&M staging of primary cutaneous melanoma. If this tumor had been ulcerated, it would be classified as a T2B. The other prognostic features that we always look for include lymphovascular invasion, neurotropism, and the presence of microsatellites. Immunohistochemistry utilizes antibodies to bind to proteins in the cells to highlight them more easily. This is a SOX10 immunohistochemical stain that was examined for this case. The stain highlights the nuclei of melanocytes in red and demonstrates severe junctional architectural atypia in the form of Paget's voice spread. Here we see a PRAME stain, which is a sensitive new marker for melanoma, and again is positive in the nuclei of the melanoma cells and supports the diagnosis in this case. Whilst immunohistochemistry can be helpful in many cases of atypical melanocytic lesions, it is often not required to make a diagnosis. The H&E stain remains the gold standard for the diagnosis of melanoma and is by far the most useful. So in addition to the Breslow thickness, mitotic count, and presence of ulceration, the status of the sentinel lymph node is one of the most important prognostic indicators. The clinical practice guidelines by Cancer Council Australia recommend that patients should undergo a sentinel lymph node biopsy if the Breslow thickness is greater than 1 millimeter or greater than 0.75 millimeters with other adverse prognostic indicators such as ulceration. This is to optimize patient management. Melanoma Institute Australia provides a sentinel node metastasis risk prediction tool on their website. This tool can help clinicians have informed discussions with their patients about treatment and risk. As per the clinical guidelines mentioned, the treatment for primary cutaneous melanoma is a wide local excision performed after the initial biopsy. For T2 invasive melanomas between 1 and 2 millimeters, which our case falls into, the recommended radial excision margins measured clinically from the edge of the melanoma should be between 1 to 2 centimeters after the initial excision biopsy. This case highlights a classic example of invasive primary cutaneous melanoma and illustrates key principles in histopathological assessment, including the importance of Breslow thickness, mitotic rate, and staging. It also underscores how pathological features guide decisions around sentinel lymph node biopsy and further surgical management. Remember that careful adherence to the established guidelines ensures accurate staging, prognostic evaluation, and optimal patient care. Thanks for watching.